I'd like to acknowledge the local custodians and honour elders past, present and emerging. Good morning, everyone. Welcome to the second session of our infection control Q&As. Beautiful day this morning, nice and early, and I'd like to welcome Margaret Jennings. Thank you for being here with us this morning. Looking forward to another informative session with you. So I'll hand over to you, Margaret, and then we'll get to the questions.
Thanks, Melissa, and I'm pretty much in relaxed mode today. I've got my porridge next to me, and no doubt you guys are you're probably feeding babies or doing whatever, but here we are, and I'm over it. So why don't we, well, I'm in Melbourne, so we're really over it. However, don't feel sorry for us because, you know, the good news, whatever news is, that something's going to happen when there's 70% of those who are eligible to be vaccinated will have had their first vaccination. So I actually wanted to spend, 5 minutes, unless the questions come in thick and fast, spend 5 minutes actually talking about your adaptive immunity and your innate immunity. And I've got a slide that I've sent to Mal that I think is really good. I've stolen it from another slideshow from somebody else, but I've given them the acknowledgement there. So I want to talk a little bit about that. The other thing I wanted to talk about was the deep clean, because I was doing some coaching with a couple of the Sydney clinics yesterday, and in the middle of them, one of them said that one of their sister clinics had just had to close down because there'd been a case there. So I wanted to talk about the deep clean because it's not sort of, it's not high tech, but I tell you what, today's the day you start putting things away, because if you've got dressings hanging around and somebody's been in there who's later a case, or who's a case determined that they're infectious while they were there, you've got to throw out a lot of stuff. So I'm very keen on us putting things away. So how about we have a bit of a Marie Kondo thought about the treatment room today, and how about we think about not having our patients in the clinic when they actually don't need to be in. I don't mean that they don't come, but you know that I'm really big on us seeing the patients, having a bit of a squiz at them in the car, and go out and have a bit of a chat. Should they actually come inside, or can I actually gauge enough, having a good look at them? And so I think if they have to come in for an examination, I don't think I want them in my consulting room, because, that's the place I want to have my cup of tea, and I want to make my notes, and I want to do my telehealth. If I've got patients in there, that means I have to wear my mask like all the time, because when the patients go, they've left their aerosols. If you rip your mask off, guess what you're going to be breathing in? So unless you've got, an air purifier, or you've got the windows all open, I really like the consulting room to be for you. Consult yourselves, all right? But think about that as your little haven. Have your coffee, tea, whatever there. And I'm very keen on you not seeing your patients in your consulting room. So I'm not a big rap for everything being on telehealth. It's not always that satisfying. But more to the point, I want to make a case for us seeing our patients, because I don't know whether you know, but 2 women died at home in Melbourne 2 nights ago with COVID. And we know that this has also happened in Sydney. And this is a real warning, I think, for all of us, that people are not recognising that they're that unwell. And one of the clinics I spoke to yesterday, they actually call their COVID cases every day, and which is fantastic. And I think they've got about 100. So remember, people, it's 2 weeks. We've really got to look after people in that time. They can be they should be getting better by about day 5, day 6, day 7, but some of them, as you know, take a dive, and that's when the that T-cell inflammatory response for some people really, doesn't do them much of a favour, and they end up with all sorts of, microclots and problems with their lungs. So keep an eye on those who are positive, because I don't think some of them aren't recognising that they're unwell, and that if you measure their oxygen saturation, with your devices out in their car, etc. Sometimes we're a bit shocked. People don't often realise that they're unwell. So let's not miss anybody. And I think that that's pretty good medicine to be saying, yep, I am seeing people. It's not all telehealth. and they're basically not coming inside. Some people have got a system where they're also doing vaccinations, and I'm very keen on you keeping the two paths of people very separate. So I think it's a better optics to have your vaccination clinic outside and maybe see the occasional patient in their car or around the back. I'm not sure that, doing, and of course people are going to have to come inside for an examination into maybe a treatment room rather than your consulting room. This is all going to depend on doors and stuff, but it's not a great look to even use a waiting room, let alone have vaccination patients. And I'm sorry, but 1.5 metres doesn't cover it. Not with this thing, not with Delta, and not with it being, it's evidently airborne. That's where the evidence is. And so to have somebody who's, come in for a visit because, something's, they're not well and they're 1.5 metres from the vaccination person, not great. I definitely have two separate systems going there. And actually there was a case of, I think somebody got the wrong injection a couple of days ago. I was told, don't want that to happen. So this thing about what happens to me, I had the shot, you might say yesterday, I feel really off today. Or other people like myself will say, sort of feel like I did a bit extra at the gym yesterday. Whereas my husband, 3 hours on the couch asleep. Other people, I'm not even getting out of bed today. And then quite a few, I'm fine. I don't feel like anything happened. So what's going on there? This is actually part of your, what we call innate immune system. And let me just sort of say that this innate system is basically cells wandering through your tissues, cells wandering through your bloodstream, your various fluids, looking for something to pounce on. So they're going to pounce on something that sort of doesn't look right, and it might be your vaccine. Now, what we don't want is those cells to pounce on all of your vaccine. So otherwise, we don't get a chance for our adaptive immune system to kick in. That's, your memory cells, your T and B. We've got the two systems, T and B. B make antibody and T make the T cells that go in and jump on cells just as they begin to get infected, whereas your antibodies a little bit later. So for viral infections, we need T cell immunity probably more than our B cell immunity. But anyway, that's our adaptive immunity, and that takes another 10 days or so before we can measure any detectable activity, whether you've been vaccinated or you've been got the infection. So these cells, this first lot that were just wandering, looking and scavenging, and they see the vaccine come up and they go, that looks a bit foreign. So they start to jump on it. But as I said, we've got something in there like our adjuvants, etc., in our vaccines that don't let the body's, cells jump on everything. Otherwise, we don't make any memory. So the adjuvant extends the presence of the vaccine so our cells can get a good look at it, our adaptive immunity. But when the innate immune system goes into action, it can make you feel crook. So you can be tired. You can go, I'm not getting out of bed, and other people, nothing. So we know about 20-25% of people, it'll be enough for them to work out, I don't feel the same today as I felt yesterday. And it was most likely the vaccine. And so that's quite normal. Now, some people say to me, but I didn't get a reaction. Does that mean it's not working? No, it just means your body is actually maybe more finely tuned to dealing with this thing. So it doesn't sort of go into a mad thing the next day. So don't forget, so there's the thing that happens the day after you've had your shot, if you get a reaction. Obviously, I'm not going to talk about immediate reactions. That's why you stay for 15 minutes after the shot. That's different. That's a hypersensitivity reaction. Not going to talk about that. I'm talking about what happens that day after. So it varies for various people, but I think it's around 22%. And yet, look, I think it's 70% can feel a bit of a sore arm. So these are just our innate systems kicking into gear, but you don't always feel them. But you see the range of things that people feel. And then, as I said, now your adaptive immune system goes into action, and probably at about day 10, day 11, we could do some testing and just find the beginning of maybe some antibody production. We tend not to measure the T cell system. It's a bit tricky. And what we say is if you've produced antibodies through the B cells, you've also produced, helper, killer, effector, suppressor cells through your T cell system. But it's your T cells that are actually more important. And that's why we don't worry about antibodies declining for infection. They should decline. They generally do decline. And however, you've also produced memory cells. And so what happens is when you're re-exposed to the vaccine, you have a booster or you have the infection or you're exposed to the infection, what happens is within 48 hours after your exposure to that infection, remember the virus has got to get in, your body just doesn't have a halo around it saying COVID-19 or SARS-CoV-2, don't come near me. The virus has got to get in and it's got to start to grow. And that's why you're hearing about, oh, hang on, I thought she was immunised. What's going on? She's got the symptoms again, but you don't get them as badly. But what happens is within 48 hours, your antibody levels shoot up to protective levels, and same with your T cells. But in that 48 hours, it might be just enough for some breakthrough symptoms to occur, that you don't get it as badly. Most people don't get it at all, once you've been immunised. But that can account for some of that breakthrough. The other thing that can account for the breakthrough infections is, of course, the immunisation is not as effective because we have a different strain. But what we do look at, and this is real time, is that people are not ending up in hospital as much once they've been immunised. So there you go. We know it's working. And the vaccine's doing the heavy lifting at present, plus you guys doing your distancing and wearing masks. So that's heavy lifting is being done by your immune system. So while you kind of think, gee, I'm doing nothing, I'm in lockdown or whatever, believe you me, your body is very busy making those antibodies and specialised T cells. So, and if you don't believe me that things are, on the improve, I can tell you the curve in New South Wales and Victoria, the rate of acceleration probably peaked in New South Wales about 2 weeks ago. So I'm not sort of saying you're going like that, but instead of going like that, you're going like that. So that's the start of that. And the same with Victoria. We're on a lower number because we just love lockdown. We went in very early. It's clear that we are not going to get to zero. We can't immunise everybody because, the data isn't out for the immunisation being suitable yet. We haven't, the work hasn't been done for kids under 12. I guess the group that I'm concerned about are the kids under 12 who've got immunosuppressive disorders. So that they can't be immunised at this point. But they could come off second best with this. So I'm looking to see what we're doing to protect the under 12s who are really at risk of serious infection. Perhaps that'll inspire more adults to get done. And you know that I'm pretty unforgiving when it comes to that. So I just wanted to mention a little bit about vaccination, but it is doing the heavy lifting. And so basically what it means is 100 of us out there, 100 people over 12, 70, 80% of us are producing antibodies. A virus comes towards us and you can see that, and maybe behind us there's a whole household. So for over 2/3 of us, it's going to be blocked. And for the other third that are there, a lot of them won't necessarily spread it. So it's not as though, that 30% will spread it, not necessarily. Not everybody spreads at the same rate. So the vaccine is actually, that is our ticket out. What it will look like is that we'll continue to get cases and they will go up. And it's considered that it will be more manageable because the hospitals will have capacity. Right now, that we're struggling. And Victoria's flown in 350 health professionals from overseas. I don't even like to think about, what's going on there sort of thing in terms of are we taking them away from countries that need them more than us. But anyway, that's happened. But the deaths follow about 5 weeks. So I think there are between 4 and 6 deaths per day in New South Wales. So you can expect that. The people who are being infected today, their death rate won't play out for 4 to 5 weeks. That's what's happened. over the last year and a half. However, the impact of the vaccine is unknown. And it may be, I have to say that most of the people, and you know this too, who are in hospital are not vaccinated, not fully vaccinated, either not at all or not fully. Not seeing a huge, and we know underlying factors is also an issue. I've got a slide that I'll also send to Melissa, and it's just a small number, and I may have referred to it last week, but it's about people who are severely immunosuppressed who end up in hospital, vaccinated, not tending to end up in ICU. So we're just getting a little bit of evidence there. However, it wasn't Delta strain. It was the Alpha and Wuhan strain. So there's a little bit of information there, but we're basically going through this real time. Will they make it available to the under 12s, and how do they actually get data on this? And yet they do actually have to do some extrapolation, or do they just grab 10,000 kids from 0 to 12? Possibly they've already begun to immunise some kids just under 12 who would benefit, and maybe we're getting some data from that. But I don't think we just go and grab a whole lot of babies and immunise them and see who, see who gets crook or see who has an effect. I don't think it's as raw as that, but gradually they work down the list. And I have to say, around the age of 12 is probably peak immunity in terms of ability to the immune response at 12 is blinding. It's fabulous. All right, we should make them more nurses and doctors and put them in the front line. All right, now there are a couple of questions. Would like to know more about gowns, when to wear and when it's wasteful. So what I would be expecting is that everybody in the practice is wearing a face mask, a surgical face mask, and a face shield, because it gives you a bit of eye protection. We know the virus has a bit of an affinity for the conjunctiva. So a mask, face shield, a bit more protection, stops you touching your mask when you've got your face shield on, and go out and see your patients in the car like that. Obviously hand hygiene, gloves if you're going to be examining, etc., etc. I sort of say that. The only reason why I'd be really wearing gloves is because I might get some secretions on my hands, and the gloves they'll just help the hand rub. When I take the gloves off, it means the hand rub doesn't have to cope with as many bugs. So the person's asked about the gown, and there is not a huge case for a gown in general practice. If I'm going out to the car to do some swabbing, different. Have a gown on, but you see, you would only be doing one, so you would take the gown off and dispose of it. If I'm working in the swabbing clinic, I use what I call, I have what I call extended use. That is, I keep wearing the same, change the gloves, obviously person to person, but I wear the same mask and face shield and gown, going patient to patient, but changing gloves. That's called extended use. It's not called reuse. Reuse would be where I took something off and I put it back on. That would be reuse. And the only thing that we really reuse are our face shields. And I think even in the testing clinics, they tend to toss them out at the end of the day. So when they have to go, have a break, and I'm very big on people having a break every couple of hours to get their stupid mask off and to maybe stop a bit of pressure on the nose. I prefer these to goggles, because goggles are going to put more pressure on the nose. And you can see some of the pictures of the nurses and doctors with the P2 masks on. So these, white front, obviously you've done your hands, white front with your detergent disinfectant wipe the back with a fresh one, pop it in a bag, hang it up, it's yours. End of the day, wash it. So no, not a great case for gowns. And I would be a little bit surprised if people were just walking around in gowns all day long, because you would not come back into the clinic, with your gown. So I would be keen. With the receptionists, yeah, they're doing the same, and they've got sneeze shields, etc. So I know that I'm speaking to a really big area, and some of you are saying, we haven't had a case here, what's going on? Well, you will have a case, and you'll have plenty of cases. So get into practice now. If you're not. The other thing about the face shield is it stops you touching your mask. And of course, as soon as you do touch anything, you've got to do hand hygiene. If somebody sneezes all over you, yeah, take your face shield and mask off. So with your face shield and mask, it's always face shield off first from the back, all right, always from the back. And you know with this, it's always 2 off together, away and down. I don't think I have to show anybody how to wear a surgical mask, but don't tie them like that because that gets you a pocket and the air starts to go in there. I want to take everything in through here, well 97%. And then the P2 masks, if I've got somebody who's symptomatic and I'm going, even if I'm going outside to see them, whip on a P2 mask, all right? I don't think I'd be wandering around the clinic with P2 masks on. Obviously, make sure you check yourselves before you go to work each morning and your household. If anybody's got symptoms, do not come to work. Take them and you to a testing station. Now, the question, so the gowns. What I would do is just recommend scrubs so that each person, each clinical person has got, 2 sets of scrubs. Take a bucket to work, get a bit of, laundry detergent, a couple of coat hangers, just a spare pair of shoes. Just have them at work. Family really don't like it when you bring your scrubs home, even if they're in a bag. They more or less, banish you to the bottom of the garden, with your bucket. So rinse your clothes out at work, hang them up in the shed or the laundry or whatever you've got, and, use the dry ones the next day. I kind of think the optics on that are pretty good too. And a lot of people really like it. You don't have to, we haven't got strong evidence of transmission. Of course, it's possible. We haven't got strong evidence. This goes back to the flu pandemic of 2009. No strong evidence that transmission is occurring off clothes and even gowns, quite frankly. But you can see when somebody sneezes at you, I think I want to have something on. But, you're not expecting that to happen. It's only when, you've got somebody who's symptomatic that you would do that for. The other question was, should disposable surgical masks be made mandatory in general practice? Yes. Let's just not see people who don't wear masks, but we know that some people can't wear them, but that's only occasional. But if you've got a patient who can't wear a mask, well, what are they doing to protect the rest of us? Yeah, they can wear a face shield and they can get hold of a face shield, believe you me. So can they wear cloth masks? Usually clinics here in Melbourne, no, you take your cloth mask off, you do your hands and you're asked to wear a surgical mask. Now that can be, if I'm seeing somebody in their car, I'm not going to do that. If they've got to come in because I've got to examine them, I think that would give me a little bit more protection because the cloth masks that they make are often only two layer, and that's not enough. So I need to make sure you guys are protected. Can I comment on the ventilation minimum standards for clinics? Well, this is for where you see a patient face to face. Open your window, I can tell you. And if you've got a door, both, as a door to outside. So you might have a front and back door in the clinic and windows throughout the practice, open them all. Because the more cross ventilation you get, the more rapid air changes. So the hospitals are generally set for 4 to 6, but I think you might see that things are going to ramp up a bit there. What that means is that the air is literally being changed over completely every hour, 4 to 6 times. This is what this is a minimum. But I have to tell you that's not for infection control reasons. That's for comfort. And it's called your HVAC, your heating, ventilation, air conditioning. So if you are in a building owned by somebody and you can't control, the dials, ask them how many air changes there are. And if they've got no idea, well, one of my practices said, I think we're going to move from the 23rd floor because it's really not suiting us anymore. We're going ground level to a single whatever house. We're going to run our clinic from there because we can see that this is going to go on and on and on, and it suits us to be able to use a car park for various things. So they're actually looking to the future and getting into the swing where it might be just quite normal to have a chat to a patient in their car before they come in or whether they need to come in, because I don't think telehealth is going to necessarily be the answer for a lot of us, not as satisfying medicine-wise. So where was I going with that? I'm just going to have a spoonful of porridge while Mel gives me any more questions.
Okay, so I've got one that's come through in regards to the autoimmune disorder. If a patient has that, such as TIDM, should they have Pfizer or opposed to Astra?
I don't give any advice. There's reams and reams and reams of advice on that. I'm not skilled or knowledgeable enough. I'm just a microbiologist and I'm sticking with that. I'm not a nurse or a doctor. And
Okay.
TDIM, perhaps somebody can educate me.
Yeah. Next one, ventilation minimums for clinics that see patients face to face.
Windows open or see them outside. Both wearing masks, of course. Start your consult. You open the patient's file, go out to the car. Your consult has already started. If they've got to come inside, if it's just for the shortest time. Every minute you're not face-to-face counts. Every minute is a risk reducer or a risk increaser. So don't kind of think, oh, well, you know, I still had to bring 5 patients inside. Well, what's the difference between 5 and 15? Huge. Your exposure is a third. That's what I'm trying to say. Oh, well, I normally have a 20-minute consult inside. Well, you know, if you can have a 5-minute consult inside because you've got to examine them, but you're having the chat in the car and you walk them back to the car and have another chat. That is all part of the consult. And so that is a real risk reducer for you. Patients love it. Some of the doctors are saying, I actually see my patients walk now and I can make some more, you know, evaluations on their state. But again, I'm not a nurse or a doctor. Now, the person asking about autoimmune, they weren't asking about immune suppressive disorders, were they? It's an autoimmune disease. Now, I'm not going to, no, I don't comment, but you know what I mean? If those questions are being asked, that's telling me that there needs to be more discussion around that.
Great, okay. Outdoor infection rates. When people, I guess that kind of ties in with the ventilation that you just touched on, is just saying the distance between people outdoors and the contagious, is it contagious? Like, can you catch it outdoors?
Okay, so what you look for is evidence. Now, what we know with Delta is that the R effective number is really between 6 and 8. I mean, last year, the strain we had was more around 2 and a bit. Well, you know, that means one person can infect 6 to 8. So what that says to me as a microbiologist is the bug, what we actually know is that it's got a higher affinity for your throat, absolutely. You know, there are little tweaks that have happened on the end of those spikes that really grip. And secondly, I don't need as many. You know, the infectious dose is probably lower. But it's still about air changes, time and distance. Now, outside you get unlimited, but you know, there's outside and outside. There's outside on a veranda on a still night. Well, that's not going to be as good as a bit of wind and right outside. So, you know, this thing about outdoor cafes, yes, there's less risk, but, you know, it might be a still day. You might be half enclosed with plastic sheeting. I know where I won't be going. I'll be in my backyard, thank you very much, having a coffee on my own until I can see the reproduction number, you know, that we're not getting one person passing it on to any more than one. Now, that's a bit of a pipe dream at present because it looks like we can't get the RO or we can't get the effective rate down below 1.2. So it means we're looking like we're going to be having this virus hanging around and becoming endemic. But the more people who are vaccinated, the much better off we're going to be. And those cases that end up in hospital, there'll be space for them. And you know that we're kind of, that's going to be, October's going to be a bit of a nightmare. And it'll be sad because we are going to be getting those cases, getting it this week in hospital and struggling to breathe in a month's time. And there will be, you know, I think in Victoria we got to 25 a day and that was pretty awful. That was after a peak of 700 a day. So I think you know. Now, I have to say that we've got better at managing it. We know that it's early oxygen, not racing to the ventilator necessarily. You know, there's been sort of some work done around that, and other ways of performing ventilation too. So that's just what I've read, but I'm not an intensivist. I think the dexamethasone, I think we've gone off that a bit, but we're a little bit keen on these. We're into the dexamethasone. What's the stuff we've gone off? One of the antivirals that mightn't be so flash. So a few things have gone into the mix, stuff that we've learned from last year, but we've now got a new strain. Now, why would I, as a microbiologist, want to drive the numbers right down? If everybody's feeling a bit cozy about, oh, I don't mind a couple of 100 cases a day. Well, I do mind, because the more this thing goes through people, the greater the risk of mutation. And can I just say, the virus is mutating every time it goes through us. Now, most mutations are lethal to the virus and they go nowhere. They don't help the virus at all. But you can see the emergence of Delta and the impact that's had around the world. So, of course, the potential is for something more infectious than Delta, less infectious, but the one that's most infectious is going to get the toehold. That's the thing that's going to take off. So this is a competition between the viral strains. And so you can see that it's Delta that's the predominant strain. There is a bit of a talk of a Delta plus, but I think it's just mooching along at present. So whether that'll take off, we don't know. But that's why I'm very keen to get as close to zero as we possibly can, because I just, the way this thing is mutating, and there's a number of genes that it uses. Some people say it's sort of used up its genes to mutate, but don't know about that. These viruses find a way. Now, any other questions there, Mel? Because I will talk a little bit about ventilation.
Yeah, there's one just come in about how effective are air purifiers, and then the last question was around the kids going back to school and helping them to stay safe.
Yeah, well, when kids go back to school, it won't be like you and I know it. You look at the UK, so they are schools open. Now, occasionally a school will have to close. It might be just for a week or two, whatever. But the way schools will open will be the kids won't necessarily move from room to room. It'll be the teacher that moves. The doors and windows will be open regardless of the weather. So I know it sounds wacky, but you might have the heater on in winter and the doors open. That's what they've been doing in England all through the winter, probably their summer, because they've had a rotten summer. There will be maybe not full classes. In other words, kids don't go necessarily every day. They may not go for a full day. So school will look a bit different. And maybe we can get a safe vaccine for kids as well. But the hardest thing is to immunise during an outbreak. We normally don't do that. This is why we can't get herd immunity. You can't get herd immunity immunising through an outbreak. Time to immunise was the first half of this year. And it just couldn't happen for lots of reasons. And you can't really, I think, blame, I mean, we can all be angry, but that's just the way it is. So we can't get herd immunity. Nobody can. Nobody around the world can. And we're probably still better off than some, you can tell. So with the school, school will go back and it will be different. That's what I'm saying. And look, you see the 3-year-olds, they know how to use the hand rub better than the adults. Primary school kids will be wearing masks going back to school in Victoria. So there will be some imposts. You can't just sort of say we're fully open, whatever that freedom day is that people talk about. There has to be some restriction, absolutely. But I think people will look forward to fewer lockdowns. There will still be the occasional lockdown. There will be lockdowns at 70% and almost none at 80%. And that's what we really want to strive for. But for me as a microbiologist, I don't want this thing spreading because I know that the risk of mutation is there. It's just ticking over and ticking over and ticking over. And eventually, you know, it finds another way that's easier for it to get to our throat. And it could possibly also bring pathogenicity, increased pathogenicity with it. So, the schools will open. Our playground's open today, and you might think, well, wacky do. But for us, this is a big thing, but it's only one adult with the kid or the children, and no having coffee. because we know what happens. People pull the mask down. So you can't have everything in this life. And in fact, the playgrounds, it wasn't the kids that were the problem, it was the adults all getting together and using it as a, morning coffee, getting close together, and it was winter, so really close, and drinking, so masks off. So you can see it's not unreasonable to say, yeah, how about we just have one adult for the kid, for the family. I don't know how it works if you've got a large family, but anyway. And yes, you can get an air purifier, and they're, I don't know, $800 for the right size, one for a room. But I would really, honestly, not be busting to go out and get one. The hospitals will be using them to supplement the air changes, to supplement. Okay, when you have an air purifier, it's windows and doors closed, because the purifier is purifying the air in that room. So the air is going through a HEPA filter. It makes a noise, and some people might go, I can't work in that noise. But people who used it maybe had asthma, stuff like that. But for clinics, I'd be a little bit shocked if everybody went out and bought one for every room in their clinic. But I tell you what, now's the time to start thinking about, well, what is going on in my building? I know nothing. So finding out how many air changes per hour, absolutely. And saying, why can't I open those doors and windows? Otherwise, maybe I've just got to buy a security screen door and I can have my front door open. So thinking differently, the way we run our clinics. Lastly, the negative pressure room. So the hospitals, the large hospitals all have at least a couple of negative pressure rooms where they put patients in with really tricky, infectious diseases. Super infectious, airborne. They'll put them in a negative pressure room, so nothing's leaking out under the doors. So one of the experiments they did in Melbourne last year was they said, well, let's actually have a look at our ordinary heating, air conditioning, ventilation system. Let's see where the air's going. Well, it was a little bit shocking, because what they found, this is just in the ordinary hospital personal rooms, each person has their room. They found, I think they did it with smoke or something, went under the doors, along the corridor to the nurse's station, under the next door and up into theirs. Bit of a shock. That was the smoke going through there. So you can see that just having your ordinary heating, air conditioning, ventilation system is not really going to stop this virus from, from air. It's moving to the wrong place. That's what I'm trying to say. But when you're in a closed room, and you're coughing and talking, and you're a COVID positive person, what happens is the airborne particles that contain the virus just hang, and they can remain suspended really for hours. So you can imagine then, if I've got a heating, air conditioning, ventilation system, that may even be carried, to other places in the corridor. That's what they were finding. So that's why they've installed the air purifiers in parts of the hospital that haven't got negative pressure. Negative pressure stops that. But, we don't have negative pressure. Not even all the hospitals have negative pressure. So hopefully that's given you a bit of a course tour. Do I have to just mention a little bit about rapid antigen testing? Can I just mention that quickly? Point of care testing is where at a workplace they will swab and do point of care testing. It's done on the spot. It is not the same as self-testing. So when you hear about rapid antigen testing, it can be either, buy it at the chemist and take it home and do it yourself. Don't do that. And they're not actually authorised currently in Australia, or it's done, by a company. So, for example, in aged care, they might do 25% of the staff every day. So there might be somebody there, and I think each machine can do about, 30 or 40 tests. So they might have 2 machines, and they can do 80 tests a day. So it's a surveillance more than anything. Is it useful where we have low numbers? Not necessarily. Where you've got really high numbers, it can be useful, but we don't have really high numbers. For example, in Victoria, a number of tests have been authorised for use, but it's pretty largely a surveillance test, because if you get a positive, and remember you can get a false positive, and that can be a disaster. In an area where there are no cases, a false positive sends everybody into lockdown like, yesterday. So you don't want a false positive. they're more likely to be false negatives, where it's not sensitive enough to have picked up the start of that person's infection. Okay, they might pick it up while they're, really making loads of virus. So if you get a positive on your point of care test, the rapid antigen test, and that's done by people who know how to do it, sure, you get the result in 15, 20 minutes, but if it's positive, what are we going to do? Well, it actually has to now, you've got to do another swab, send it off for PCR. So what's actually happening in a lot of the nursing homes here is that the pathology companies are just saying to the staff, well, listen, here's 100 tests, 100 PCR tests. You guys do your own. We'll have the result for you that night anyway. And that's a very accurate test, the PCR. So in the meat industry, transport, I think Victoria and I know New South Wales has started point of care testing. So it's surveillance, and you've got numbers circulating. So it actually is really beneficial to be doing point of care, but it does have its limits. But you've got to actually confirm any positive. And who's going to give the person their result? They're sitting outside, waiting for their result. You see positive, I would want a health professional giving that sort of result, because that's got implications for the whole place. But I would act as though it were positive, and it most likely is positive, but the whole place is, really got to start closing down. But you would get your PCR done straight away, prioritise it and get the results back that night to confirm that it's positive. But don't do the at-home test, please. Can you imagine people faking the results on that? So I think that's enough. And do we have any more questions?
No, that's it. And we've run a little bit over time, but it's very interesting.
Thank you so
much. No, it's amazing. Today is being recorded and, of course, will be available on our website. A survey will pop up at the end of the session, and we strongly encourage you to complete the survey so we can get feedback for future education events and topics. That input's really valuable. And I really wanted to say thank you, Margaret, for being with us this morning and presenting today. There's some great information there. And also thank you.
Time for me to thank all the the people who are watching, because believe you me, you guys are under the pump. It's all right for me to sit here barking orders, but you guys are the ones having to do it all. Okay, thank you.
Yeah, and thank you to everyone out there as well. And I wish everyone have a beautiful day. Thanks, Margaret. Thanks, everyone.
See you later. Bye-bye.